All right, well, good evening, everyone. My name is Shyam. Thank you so much for being here tonight. Quick introduction to what this initiative is part of. I know most of you are from AED, but this is part of a separate initiative called PhysiLink. It's basically a platform meant for personalized mentorship and education, especially for people on the pre-med track, but also for anyone on considering a pre-health track. It's an online platform where you can chat with different doctors, get personalized help, and then we'll host webinars. So Dr. Tarun is the resident of the month, and every month we'll have different doctors that are resident or that are featured, and we'll also have a physician, current practicing physician featured as well. And each month we'll try different specialties and different physicians. You could go through all of our previous physicians that we have listed on here. Um, and they also have questions that they've answered. And you kind of just scroll through, learn a little bit more about each of these physicians. If you want to reach out to them, any of them personally, you could always reach out to us and we'll kind of put something together. We have a newsletter that we encourage you to stay updated with. We'll type in that will let you know about our different webinars. And then finally, we post all of our webinars on YouTube and then also have podcast episodes in case you want to listen to them as well. So you can kind of go through all of these. I'll put this link in the chat real quick. Once again, if we host a physician or resident in a specialty that you are particularly interested in and would like to talk to the physician or resident further, just reach out to us and they'd be happy to help you. And we rotate out every month, so there'll be new doctors every month. All right, so introduction for Dr. Tarun. He's a dedicated family medicine physician and upcoming hospitalist at Aiken Regional Medical Center. As core faculty for the family medicine residency program, he will mentor residents in research, data analysis, and quality improvement. Passionate about advancing evidence-based medicine, he played a key role in integrating the National Inpatient Sample database into his program, providing trainees with hands-on experience in clinical research. Throughout residency, he has presented at national conferences and contributed to multiple manuscripts. Outside of medicine, he enjoys collaborating on research projects and exploring innovative approaches to healthcare data analysis. Dr. Thrun, is there anything else you'd like to add to that introduction?
So, in addition to that, I like to add outside of medicine. I like to go out with my family, spend most of my time with my family, and spend with my niece and nephew who live in Augusta. So I like to spend more time with them. And traveling, I really love to travel. So I travel to multiple places, so multiple countries too. If I get time, if I want a vacation like 1 week or anything. So yeah.
Thank you so much once again for being here. We're excited to learn from you. Just kind of to get started, um, can you just explain what it means to be a resident, and then also talk a little bit more about what it means to be a family medicine resident?
So, to what it meant to be a resident from my side, it's like, honestly, it's a tough job, first thing. And when you go through your residency, you're going through a rigorous training as a physician, and you will learn a lot of new things and with the patient interactions and the work hours. And residency also teaches us a lot of balance in the work life balance. Because you work 80 hours a week, it's not a small amount you work. Like, it's not like every program makes you work 80 hours, but the ACGME criteria tells us the maximum we can work in a week is 80 hours. So most of the programs meet at 70 hours for sure. So 70 hours a week, that's a huge also for a person to work. And you get a 1 day off in a week. It's not like 2 days weekends off or anything. 1 day off. In that 1 day, you need to take care of your family. You need to take care of your personal things. And this all needs to be managed in a proper way. I think 3 years of residency teaches you a lot. And in the view of family medicine resident, you see a diversity, and also you see it's more of like you enjoy yourself in each and every case. It's you no need to interact with adults if you're not interested. You can interact with children. You have a liberal thing that you can interact with any of the family members, because you read whole of the medical school. When you go into residency, I see this way, When you go into a particular field of residency, you just miss the pediatrics, you miss the geriatrics, or you miss like the OB. But down the road, after 3 to 5 years or like 6 years in practice, when you go in, suddenly a family member calls to you of your family, being a doctor. They call you, okay, oh, I'm pregnant right now. I'm taking this prenatals, or like I'm taking this medication. Is it like a valid medication that I can take it? It's, so you can search it up. You can just give an answer. But being a family medicine, they trust you more answers because you treat them, right? And you interact with them every day. And the experience you get in family medicine, it's a wide diversity. And and you can tailor your practice. You can learn your practice. Either you can go into the ER, you can work as a family medicine physician, works in the ER, because they're more, I can say they're more of like practice, like procedure oriented people. The family medicine residents, like family medicine physicians, are more procedure oriented, and they learn a lot of procedures which can be done in the ER, urgent cares, as well as in the primary care clinics. And this free hand for you will really help you a lot in medicine in the future. That's what I see in family medicine. When I joined as a family medicine, when I'm choosing the family medicine as my residency, this is what I choose. Like, do I need to leave the OB? Do I need to leave the pediatrics? Because I want to treat those. And down the road, I don't know. I may be interested in treating the pediatrics kids too, like a mixed population. If I have 20 patients in the panel in the primary care, I can have like 10, 12 patients of adults, like 3, 4 kids, 4, 5 OB. That gives you a more of practice, and like it gives you more of diversity thinking and everything too. You need to switch your minds.
Got it. Yeah, thank you so much for your response. So just a couple clarification questions.
Yeah.
So family medicine is 3, or family medicine residency is 3 years, correct? Or is it 4?
Yeah, it's a 3 years residency. Uh, mhm.
And then you mentioned there's a lot of flexibility. So they're seeing, you could see patients anywhere from infants all the way to geriatric patients.
Yeah, that's true. We can see from the infants, geriatrics, as well as the OB, including the women's health too.
And how does the flexibility kind of look? Like, how do you end up choosing patients? Like, are you assigned patients, or are you able to kind of focus on a specific age range that you're interested in?
So in residency, when you're there, so your practice is built in all of the fields. Like you have all the patient population, because we need to get trained in all the patient age population. When you go into the practice, you can choose depending on your comfort levels, depending on the practice where you work. But usually, when you go into the rural part, like I can say the Aiken, the rural part, where you need to be a physician who can treat all of the age groups. Yeah, when you're in the urban cities, you can choose your practice like a adult or like a pediatrics or anything. But when you're in rural, you need to choose to see all of the patients. Is it is it okay that you can hear
Yes,
me? Yeah.
that makes sense. So can you, so obviously as a family medicine, you mentioned seeing all age ranges. Now, what makes you different than, let's say, a pediatrician or an
Mhm.
internal medicine or internist? How does that kind of look differently?
So how I look at I can say that how do I look at differently is like a family physician when comparing to the other specialties. I would say like a family, when a patient comes to you, he may be a 30 years young gentleman. You can be his family physician, like seeing his whole family. He may be having like 2 kids. He may be having his grandmom, mother, who are like 50s, or grandmom above 80s. You can see everyone. You can see his wife who's a pregnant or anything. You can see that antenatal care. That will really help the family to have a bond, and you will know more about that family than a person seeing the 30 years only person. You will know like what is he going through. Okay, he has his mother who has a multiple comorbidities, it will affect his social determinants too. It will affect his social determinants of taking medications or anything. You will know. You don't need to ask. You'll be a part of his family.
So would you say that kind of makes your job a little bit easier that you're able to have kind of a close bond with all family members or just more connected to your patients?
Yeah, it gives a more connection to the patients and the family. And also, I can give you an example of one of my patient. I won't reveal the name. So he's a patient who has this anxiety, like a severe panic attacks. So if I'm seeing as a physician only him, I would treat his panic attacks with some medications, with some psychotherapy or anything. I would send him back home. I wouldn't know his wife is also of our clinic patient, and his children is also of our clinic patients. We wouldn't know his social determinants. Why is he having panic attacks? Is because of his living conditions? Is because of his past history, which he cannot reveal, which his wife can let us know what has happened in the past or anything. I don't think so. That one we won't get in any of the fields. That's my personal opinion on it.
Yeah, that makes a lot of sense. And so you kind of went into this a little bit, but can you start talking a little bit about types of cases that you typically see, I guess, from
Mhm.
the pediatric population, um, maybe middle age, and then all the way up to geriatric? What patient or cases do you typically see, and then at what point do you kind of give a referral to another specialist?
So, from the pediatrics, we would see from the wellness visits, from a newborn visits, from the wellness visits up to the sick visits, like any sick visits like upper respiratory, lower respiratory tract infections, general flus, or weight loss, weight gain from the kids. And those are the things in pediatrics. And we refer them to the specialist when it's very rare to refer them unless they have like a rare disorders that we think like a person coming in saying that he has diarrhea, and we work it up at the point that like a general workup for the disease, and then at some point if it's not resolved with the primary care, then we'll refer him to the GI or infectious disease or anything that's needed, if any procedures are needed. For the adult population, I can say that any we see the diversity in adult populations about autoimmune disorders, GI, neuro, and everything. We generally don't refer everyone to the specialist, but if it is needed a procedure, or like a patient coming with a heart failure or like a cardiac disease or with risk factors, he needs to get a procedure, or you need an opinion of the cardiologist whom you think like, okay, this patient needs to get a cath, or this person needs to get a colonoscopy, this person needs to get an endoscopy, or this person requires autoimmune disorder, this person requires to be seen by the specialist, then we refer them usually. If it's like, but primary workup, major workup will be done by the primary care physician, like we, the family physicians. And in regards to the OB, we can see the OB females up to 34 weeks. Upon 34 weeks, we can see them, but we should have a OB doctor as supervision for us. If it's like on high risk pregnancies, like a twin pregnancies, any high blood pressures during pregnancy, any thyroid issues, or any disorders which she has chronic medical conditions. So those cases should be referred to the OB doctor. We cannot do that one because the deliveries will be complicated a little bit. And in regards to geriatric, we see a lot of we don't refer usually. We just keep them because family physicians in our clinic, we have a geriatrician who takes care of those patients too. We have an adult, and geriatricians will usually be there. Yeah.
Okay, so you mentioned a lot of I guess in pediatrics it's kind of just wellness visits, but there's kind of a lot of diversity in terms of what patients and symptoms you might be looking at. And
Mhm.
I feel like compared to other residencies or other specialties, you're just seeing a lot more variety. So how does the training kind of look like so that you're well prepped to see that much variety in terms of cases?
So the training, so what the training is like, your continuity clinic, you usually have your own continuity panel of patients. Every week we need to be in the clinic, whatever rotations you are in. You're in the inpatient side, you're in the ER, you're doing a surgical rotation, or you can do a OB rotation, but you need to be in the clinic at least 1 or 2 app days of your clinic because you have your own continuity patients. So how is the continuity patients will be built up? It takes time for the practice to build up, but when it's built up, it will be like you'll have 10%, 20% of pediatric population in your whole panel, and then 30 to 40% of geriatric population, and rest of them will be adult, and 10 to 15% will be the OB care. OB is a bit of lower 10%, I can say, unless it's a normal OB care.
And do you have a supervising physician that kind of helps you oversee this panel, or is it kind of up to you?
So in the first year, in the first 6 months, when you started your residency, you have a supervisor for every patient that you see them, whether it's a low volume visit, low care visit, like a we bill them, right? It's level 3 and level 4, we grade them level 2, level 3, and level 4. Whichever level you're seeing in the first 6 months or first 12 months, you need to have a supervisor who need to come in with you and see the patient. When you go to second year, so the level 3 visits can be seen by you. The level 3 visits comprises of any patient without any change of medications. You're doing that visit. Just you have a high blood pressure patient. You just ask him to come back after 6 weeks after giving the medication, and you just see his blood pressure is okay. You're not changing any medication. It's a level 3. So those visits need not to be seen by the supervisor. You can just see them. You can just bill them. You can just send them. But level 4 visit, if you change any medications or like if you change any treatment plans, if you're taking a new decision, those need to be let the supervisor know so the supervisor can come in and talk to the patients regarding the plan. That's one way. And so if you have any question, you're stuck in some patients, it's a level 3, but you're stuck in some patients. So then also you can go with supervisor and talk to him. There will be always a provider preceptor for you there who will be there on site for you to help you with the patients.
So it looks like it kind of evolves a little as you get more experience within
Yeah.
the residency. So you mentioned there's levels 2 through 4. Can you just talk a little bit more about like the criteria for each of those levels, what they
Mhm.
mean, and what the levels are typically used for, other than like this case you just talked about?
Okay. So level 2, 3, and 4. So level 2, it's rarely I see in any cases in my whole of 3 years of residency. I rarely saw a level 2. I can say like 1 or 2, I guess. Level 2 is nothing like a young person, 25 years, came with a wellness visit saying that, okay, I need a physicals. I just need a sports physicals or like a physicals. Those comes in level 2, you can do it. But level 3, a person have like any, any disease like a blood pressure high or diabetes or like any disorders, any chronic medical conditions that you're seeing those patients for regularly, once in 6 months or once in 12 months or anything, those comes under level. Any anxiety, depression, like I can say like any mental psych disorders or anything, so those comes in level 3. If you're not changing any treatment plan, first thing, if you're not taking any new decisions for the patients, you're just ordering those regular labs as we order for the kidney disease patients and diabetes patients or anything, those comes under level 3. For the level 4 visits, it's a visit where we change the medications, where we think about a new treatment plan or any new labs you're ordering, any new diagnosis that you diagnose in that visit. That's one of them. In addition to that, we also have a procedures if you're doing in the office, like incision and drainage and cyst removals, and also any biopsy samples. You're taking like punch biopsy or like a excisional biopsy you're taking in the office. So those visits will come under the level 4 because you're diagnosing a new disease and you're treating for that. So those come under the level 4 visits.
And what's the purpose of having these levels? Is it primarily for just billing and like determining if you need a supervising physician, or are there any other reasons?
So this primarily for the billing, primarily for the billing and the annual revenue and everything for the hospital. So from the resident's perspective, it's about you will also know like which patient can be seen the supervising physician, and it will also help you to know, because after residency you're going to go out, you're going to go practice. You're practicing medicine by yourself, where you need to bill your patients, you need to know the finances of your clinic, because every practice runs on finances eventually. Um, so you need to learn about the finances, the business aspect of the clinic, where the clinic can be run and you can help more and more patients. So these visits give us like the finances, and you know how to bill the patients, how to bill currently. Overbilling is not right. It's a scam. If you underbill also, it's a scam. If you do a level 4 visit for a patient, you wrote a note saying that patient having some abscess, you drained it, and you'll build it level 3. It's a wrong thing. It's against the law. Yeah.
All right, that was pretty thorough answer. Thank you so much. And then we also talked a little bit about the structure of residency. So you mentioned that you're going to clinic, you have a panel of patients. Now, are there any like exams or like lectures that you have to attend? Like how does that work with residency, especially family medicine?
So for the family medicine, we have like lectures we have every once in a week. One half day will be the dedicated didactics day. We have didactics half day, I can say. In those half day, we'll in a month, like fourth, we have Thursdays every week. On Thursday afternoon, I have these lectures. So in those lectures are the mixed lectures where we do case presentations, where we do journal clubs, and we also do M&Ms like mortality and morbidity, where it defines like where we can improve the patient care, where we miss something, someone has missed in the hospital, we just found out. It's just learning opportunity for us, how we can change it, how we can change the system that will help the patient, the betterment of the patient. That's one of them. And also we'll have this case presentation, a lot of case presentations, and one first Thursday and the last Thursday we have a procedure day. That usually we have a ultrasound day, where we learn the ultrasound like 1 to 2 hours. Then we go down to the patient's rooms. We request them, can we do an ultrasound? We see like some abnormal cases like heart ultrasound, because point of care ultrasound has been very Medicare, and like many of the hospitals are expecting the residents, the physicians, the upcoming physicians to learn about the point of care ultrasound. And it also helps you to learn to do the diagnosis, actually point of care ultrasound. So these things will be there usually in our lectures days.
Okay, got it. Thank you.
Yeah.
All right, so we're getting kind of close to the halfway point in this webinar. If anyone has any questions about family medicine or about his journey, feel free to just enter that in the chat and then we'll go over it. So next question. So at the beginning of the webinar, we kind of talked about how you might be in the emergency department, you might be specializing in OB. I guess your introduction also mentioned you wanting to become a hospitalist, maybe. So
Mhm,
how does or at what point do you decide like where you want to go in within family medicine
mhm.
and what are I guess what are kind of all the different areas? So we mentioned those three, but what other options are there?
When you do your family medicine residency, either you can go as a family practice physician, like seeing adult populations. That's one of the scope of practice. The other practice is full scope of family medicine. What does that mean? Full scope of family medicine. Full scope of family medicine means you see you go to a practice where you work in the outpatient, you see your patients, you come back to the hospital. When you admit the patient from the hospital, from the clinic to the hospital, you come and see the patients in the morning for rounds. If you're doing deliveries, you come and do deliveries. It's pretty intense practice, where this practice are there in US. In many of the locations, they're still practicing this type of practice, where they're seeing good results of it. And you also see a geriatric. That's called the full scope practice. And you also do the gynecology, like the pap smears, you order mammograms, you do the breast examinations, women's health, the mostly like women's health. So these practices is like full scope practice. That's one of the way. Hospitalist is one of the other practice which is there, where you work only in the hospital, where you see the inpatient side of adult medicine. And some of the practices, like some of the hospitals are giving like where the family medicine can work as a pediatric hospitalist, where they can treat the pediatric as well as the adult population also, like in a mixed population. So very rural places. And other practice, other job you can try is the ER, where you go, you can work in the ER as a ER physician. These are the things when you do a family medicine, you come out, these are the job opportunities I've seen. Yeah.
So these are things that you would explore during your residency, and then when you're completing your residency, when you're trying to look for a job, you kind of pick and choose depending on your interests, right?
Yeah. When you're doing your residency, you will know which one suits you better. When I did my residency first year, I thought like I'll be a primary care physician when I started my residency. I never thought that I'll be a hospitalist. I'll be honest with you guys. I was full scope family practice I want to do and everything. Then eventually I felt like no, the hospital medicine is pretty cool. Like I can do many procedures. I can do ultrasound on the patients. I can learn more about hospital medicine. I can improve some quality projects. So that made me choose the hospital medicine in by the end of second year.
Yeah, that's interesting. When people typically mention the family medicine specialty to me, I think the first thing that comes to mind is just primary care, and I don't even consider like alternatives like hospitalists. So that's really cool. Um, we also talked earlier a little bit about like urban versus rural family medicine. So how does the specialty look any different in urban populations versus rural populations, or does that really depend on, I guess, the hospital or practice that you're at?
So the population depends like the patient case mix index. These are the words which they use. It's severity of the cases and the chronicity of the medical conditions which are there in that location. Usually in a urban area where you will have a lot of specialists which is available, like a GI doctor, like a surgeon, super special surgeons, like anything vascular, you'll have the availability of them. They can get through. For the rural, it's very tough for them to get in those practices. They'll be a little more like you should be more cautious when you're working in the rural, and you will be seeing what I've seen in Aiken as like it's a more rural area. What we say it's not an urban area. I can say it's a rural area. So where we see a lot of severely case mix index really. The each patients will have like 5 to 6 chronic medical conditions. A patient coming with 45 years, you cannot expect that he's young. He's young, but in terms of medical terms, I can say he has 4 or 5 chronic medical conditions. As a physician, when you go into the room with him, you need to discuss with each and every chronic condition to him. It's not about the medications you give him. It's about the education you give him. It's about the literacy you give him about his medical conditions. That is where I've seen the cardiologist as well as the physicians are moving towards. That's a new era of medicine. It's a lifestyle medicine which is coming up that says that you need to educate the patients regarding the healthy things. Like the exercise is also one of the things. The what is the medical condition he have? What can be the future? Like these things will take time, and these things I think in rural practice you need to spend more time because you are the only physician. In the urban areas, I feel like you do not spend more much time because you refer them to specialists, right? Eventually, so and they get in fast.
Yeah, so health education is kind of a common topic that comes up during a lot of these webinars. And previous physicians have mentioned
Mhm.
like not getting or not being able to allocate adequate time to talk to these patients. Is that
Mhm.
something that you have to deal with, or do you feel like you have plenty of time to talk to patients?
So, Sham, I'll be honest. See, we have so there are two things we need to think about. One, the finance aspect, other the patient aspect. When we see a patient who's following up for you after initial visit, it's like 15 minutes of the visit. In that 15 minutes, I'll give you the structure, which I'm also really, I don't know where this 15 number came from. I'm really searching that 15 number, from where does this number came from. The patient comes from the room, from the front desk. By the time he walks towards the vitals area where they check the vitals, their 5 minutes are done. 5 to 7 minutes are done. By the time the MA, the medical assistant, talks to him about the medications, refills, and everything, the 10 minutes time is done. By the time the patient is handed over to me, 12th minute I get the handover of the patient. And I have 3 minutes. By the time I need to walk from my desk to the room, right? At least it takes time for me 2 to 3 minutes. So 15 minutes really, it does not sufficient for us. As a primary physician, what I struggle is like when the patient comes with 6 to 7 troubles. So initially, when I started my residency, I used to go ahead, talk a lot of time to the patients. I used to back out like every time my clinic used to be like 30 minutes, 40 minutes, 1 hour. I used to be extra in the clinic. I need to work there 1 hour, 1 hour more. Then I used to leave 1.5 hour. I used to come home, chat again. I used to not chat or anything over there. So that eventually one of my providers told that, see, talking to the patient, educating the patient, that's a good thing. So you can see, just divide it. He has like 6 medical problems. Two of them are very severe that you need to give education. Concentrate on those two things. Give him a follow-up visit. Now you're doing labs for him. Give him a follow-up visit within like 4 to 6 weeks or 8 weeks. Tell him to come back. Change something. You talk about the next two problems. So that way you can just prioritize your visits. But I remember the time is not sufficient talking to the patients.
So is this system like kind of something that you figured out on your own, like this would be the best way it would work for me? And then like you kind of perfected it over time, or is this kind of just something that others have told you to follow?
So this was told to me one of my supervisor in my early second years, like when I'm starting second year. But then I got to know like, okay, that I tried it for almost like 3 months to just know like, is there anything I can see the patients are giving a lot of callbacks to me. Like, you'll know, right? If the patients are leaving a lot of messages to you, give me a refill, give me this one, give me education or something, that sort of. So I've seen that one. I've seen that pretty much worked for me. So I'm using the same thing since past 1.5 year. I guess that's working. But prioritizing which one needs to be spoken in the first visit is very important. That you will learn as you go along with the practice.
Yeah, as someone who kind of is really passionate about health education, it's easy for me to be like, I really want to spend time with patients and make sure that they
Yeah.
understand everything and feel educated. But I guess like in real life, it's a little impractical, and you do have to come up with different strategies like that. So thank you for answering that. So we have a kind of a self-reflective question that came from one of our listeners. The question is, how do you perceive failure and how do you manage to overcome them?
Um, so how do I perceive failure? Okay, this question was asked to me during my residency interview too. So I can say like during my med school, um, I'll be honest, like I did not do well in the first year of my med school because I got into med school. I was so excited that okay, out of like I came from India, so I did my med school back in India. In India, getting into a like a federal government funded schools is very tough to get in. If you do a MCAT same way, there's a test over there. If like 3 lakh people write the test, only 1,000 people get into the federal funded medical schools, which are cheaper. Like you just pay a little bit of $200 every year. That's way cheaper, right? So I got there. So first year I was very excited that okay, yeah, I got into this med school. There's nothing much to read or anything. I know everything. So I didn't do well with my first year of med school. I really had a bad grades at the time. And I think in 6 months I failed a test, but that failure did not define me. So then I understood one thing: success and failure. Success comes to you. It's not like it just comes to you and you're free out of it. You're done with MCAT. You're done with your SAT or anything. You're done with your. At that point, you worked hard. You got it, and you need to maintain that success. That's perseverance. That's resilience. That's most important. This one I learned it in hard way by losing my grades in the first 6 months. So I think that 6 months when I lose my grades, I was I was depressed actually. Honestly, I was depressed and I was just sitting in the home. My father came to me, was talking to me like, "What happened?" He's like, "I did not get good grades." He said like, "Yeah, I know." Like, "How do you know?" So I'm like, "Yeah, because you got into the med school and you stopped studying anything and you were just enjoying yourself." And you're saying that, okay, this is nothing. The anatomy is nothing. Like it's just arm and legs. No, my father, he knows about medicine a little bit. So he's saying, no, anatomy, you need to learn about the nerves. You need to learn about the muscle origin, insertion. So like what are the anatomy behind the body without knowing anatomy? So what do you treat the diseases? So yeah, failure is something like you'll get throughout your life, everywhere. But it's an opportunity for you to learn from that. It's really an opportunity.
Yeah, definitely. I'd have to agree. I feel like the biggest lessons in life have come from past failures. So
Yeah.
definitely second that. Um, all right. So kind of a branch off from this question, a common topic that we like to talk about during these webinars are like mental stress and burnout. So you mentioned that you work, 70 hours a week, working six
Days in a
and
week.
then you also manage to kind of spend time with your family. You talked about spending time with yourself and traveling and that kind of thing. So how do you manage to balance all of that, and how do you avoid getting burnout?
So to avoid to get burnout, only way is like you need to enjoy your work. Whatever you do your residency, you need to enjoy. Whichever residency you're choosing, if you're enjoying it, treating the patients, being there, working there, if environment is really good for you, you're not going to feel the burnout. And in regards to the family, I can say like my family is very supportive with me, and my wife, she really very supportive for me. And I know that she knows that I'm not spending much time with her because of my residency, but she understands that okay, he needs to do his residency, he needs to do his work and everything. On the day of my off, I spend maximum of my time and also with my family. I don't touch anything. I don't read anything on that off day. Always do your readings, always do your curriculum, whichever you want to do, just do in your work days. When you're working, you're not going to see the patients all the like all 10 hours, right? You're going to see the patient for 4 to 5 hours, 6 hours. Rest of the time you'll be there. If there's any calls from the nurses, if there's some pages from the nurses, you'll just need to answer those pages. So in those time, you can just do some questions for your boards. You can just read some topic that's for your boards too. You can just do some projects, getting some research ideas or anything. But when you're in the work, just be with your work. That's it. When you just come out from your work, just don't think about the work.
So me personally, I've tried to implement that strategy as an undergrad student where, if I'm trying to sit in a spot and work for 8 hours, I try to set myself to do that. But I guess it's hard to stay like disciplined for the entire time. It's easy to want to take breaks. Like how do you deal with that and just working 8 hours straight?
So when you're working 8 hours straight, you will have breaks a little bit in between. You can break yourself like 1 hour. You see now. I can just give you an example in the clinic. You're seeing a patient now for in a residency time. You'll see the maximum is like 10 patients. That too in third year you see, but not in the first years. First years you'll start with 4 patients, then six, eight, then eventually you go to 10. 10 patients you see in third year. So you don't have that much. So by the time you go to third year, you know about those patients because they are your continuity patients. And a person comes, X person, you know about him before coming. Oh yeah, I know this person. He has this X and this conditions. Just when I see my list of my patients that half day, I just see, okay, this patient is going to be done within like 20 minutes. Okay, I'll just finish this patient, then I'll just spend extra time with the other patient, manage the other patient. And you'll have a little bit of breaks in between. Take breaks in between the hours of inpatient or anything. Just take a break, just go to your lounge, relax for yourself, just eat something, or you can just have a chat with your friends, you can chat with your co-residents. So that will help you to relax.
Got it. Thank you so much. All right, so I got two more questions, and then we'll see if anybody else has any other questions, and then we'll kind of wrap up. So, are there any like fellowships that you could pursue after doing family medicine residency?
Yeah, we have few fellowships in family medicine residency. Like you can do a geriatric fellowship where you see in the older age population above 60 years. With that, you can go and work in a nursing home. You can be a nursing home physician, medical officer over there. And you can also do a OB fellowship where you will be more inclined to do a C-sections too. You'll be trained in training the C-sections. Then you can do your deliveries and everything. Because usually we do normal deliveries. With a C-section, we need to have more practice on that. So if you do OB fellowship, you can do that one by yourself. That's one of the fellowship. And the other is addiction medicine fellowship, where you can have your own Subox clinic and you can treat the Suboxone patients, methadone and everything the patients. And also you'll have specifically like sleep medicine fellowship and a pain medicine fellowship. And also you'll also have like a ER fellowship, but there are only few programs which are offering right now.
There is a lot of flexibility even after doing a family medicine
Yeah.
resident to go into different fields, and most of these fellowships around 1 to 2 years-ish.
Most of the family medicine fellowships are 1 year. Only I think that's OB fellowship, which is like 2 years, I believe, and the rest of the sleep, pain medicine, rest of the fellowships are 1 year.
Okay, got it. All right, so one more question. So most of us are undergrad students, but
Mhm.
let's say we're all third year medical students. What would you say to a student that's considering family medicine? What would you say to convince them to choose the family medicine specialty?
So I can say only one word. If you want your practice to be joyful, seeing a kids and the OB care, and you want to practice the medicine which you spent your 4 years of med school reading about it, you want to be in that field all throughout your life. So I think the family medicine is a choice. And procedures are the one where you will be more oriented in family medicine. If you like to do procedures, family medicine is a field for you. And also, if you want to go for a baseball, like a game, you want to see the games. If you want to be a sports medicine doctor, you can be a family medicine too. I forgot to let you know the sports medicine fellowship also we can do. I forgot about it. So you can be a sports medicine doc, where you can be on the field, going with your team, going to the NFL too, if you are lucky enough.
So family medicine is really for people who, want to see everyone and also want to see everything basically, because there's
Yeah.
literally a ton of variety in what you could see. All right, so before we wrap up, one last question for you.
Mhm.
So as I mentioned, some of us are high school students, and then we have primarily undergrad students. What
Mhm.
advice would you have for us kind of figuring out our niche within healthcare? Maybe not all of us are pre-med, so our niche within healthcare and advice for our careers or future. Do you have any advice for us?
So I can say only few things about the niche, about the medical career if you're choosing it as a high school person, if you're choosing a medical school, medical as your profession, sorry, medical as a profession. So you need to work, you need to work by yourself and you need to enjoy your medicine because medicine is changing every day and you should have that thing like you need to learn everything every day new things and that learning and that inquisitive mindset you need to question it. Okay, a study comes in, says that, okay, this X medication is very good, and next day study comes and says Y medication is really good. You should have that inquisitive. Is that medication is going to work with your patient population? And also situational awareness of your area where you work. And enjoying the work is most important. Enjoying the med school, enjoying your seat, and you really make some difference in the patient population for sure. If you're a doctor, you really make a lot of difference in the patients, and you will see it when you treat the patients, when you see the first time when you come out from med school and you treat the patients in residency, you'll see the happiness and you feel like, oh, this is what I worked for 4 years of college undergrad and 4 years of med school. This really had a worth.
So just a quick follow-up for that. So you mentioned we really have to enjoy our career and our journey,
Yeah.
but I'm sure med school and residency has its ups and downs.
Yeah.
So when it is tough and when you feel like, maybe this isn't for you, like what should we do? And do you think like we could really find our niche within medicine, even if we think it's not for us? Or how do we kind of go about approaching that challenge?
So only thing I can say that right now, if you want to find a niche in medicine, don't go with the preset mindset like saying that this is what I want to do in the future of medicine. Just go with your open mind into the undergrad and go into the, and if you want to do really the medicine to learn how I learned, how I can just say like how I got interested in medicine is like I used to read these articles, I used to read about the research. That research made me more inquisitive of the medicine. That inquisitive mindset really made me choose the med school. And before going, just see the pros and cons. Like everything, every field has its pros and cons. Not only med school, every field has its pros and cons. It's about the working hours, it's about like pay, it's about like the work hours. The med school is like 8, 11 years. After 11 years, you'll see the fruit of it, honestly. 4 years of undergrad, 4 years of med school, and 3 years of residency on average, then you see the fruit of it. It's a long journey. So when I just started this journey, I was only concerned about, only thing I know that I was just doing pros and cons, saying that the working hours are high, first thing. And next, I'll be at the very end, long back, as my family, everyone, my friends and everyone are going to work and everything. They're enjoying, they're going to go to the Barcelona or some vacations, Europe or anything. But I'll be in the med school, I'll be reading some books. But at that time, only thing I thought like, okay, but I chose it. I chose this medicine field because I want to do something else. I can choose something else too, but you chose it because you meant to be a doctor. That's most important. That thought needs to be there with us. So I don't think so that niche will, you'll get it when you go to your clinics, or you just see that, go to your nearby clinics, go to a free clinic, go to a senior life services places, see those people, talk to them, interact with them. You'll We will learn that interest in it for sure.
So I guess this is kind of like the idea of having a calling for medicine
Yeah.
rather than, and then I really liked how you said maybe have an open mind. Don't just be dead set on
Mm.
pursuing a career in medicine.
Yeah.
Like follow your interests and have it lead you to medicine rather than just jumping ahead and
Yeah.
picking medicine. All right, well, that kind of concludes our webinar. If anyone has any questions, feel free to stay back and ask him. He'll be featured for the rest of the month in March. So if you want to meet with him one-on-one or organize anything for any of your personal advice, you can. Um, we'll have a podcast episode and a webinar posted in the next week or so. And then I also put a link to the PhysiLink website. We'll have a lot of cool specialties coming up. We'll also another doctor webinar on March 31st at 5 p.m. That's a Monday. So if you're interested, make sure to attend that. But if not, thank you so much for attending and have a great rest of your night.